I know. Soon after that, you got all these things, no? Oh God. Then what happened? Then now at last, that's what. As soon as you came, huh? Huh.
Wait, hold on. Yes, I promise. Yeah, let's go. So, Dr. Anuj, we are going to have which is acute flaccid,
Yes, sir.
paraplegia,
Yes.
quadriplegia.
Acute paraplegia, sir.
So, the case presentation model is same. You will tell the presenting complaints, history of presenting complaints, past medical history, family history, personal history, summarize, and at the end of the history, you will tell functionally what is the syndrome, physiologically what are the tracks involved, anatomically where is the problem, what is the probable etiology. Then we'll go for the next step, examination.
Yes.
And examination, first you do other systems, come to neurology, describe, and then you give your diagnosis. Then we'll do the investigations part.
Yes.
The history taking, first you will tell localization history, then etiology history. There will be questions at the end of the history, at the end of the examination, and finally some comments. Okay,
Yes.
you can start.
Yes. Sir, my patient, Mr. Tanaji Bhikule, 52-year-old male, right-handed, resident of Hadapsar, Pune, laborer by occupation, informant being self, history being reliable, came with the chief complaints of bilateral lower limb tingling since 1 week, bilateral upper limb tingling since 5 days, and bilateral lower limb weakness since 3 days.
So the sensory complaints are positive, and there is one negative complaint,
Yes,
that
sir.
is weakness.
Yes, sir.
And all these things are over 1 week.
Yes, sir.
And in that 1 week, they were progressing
Yes, sir.
by the time he came, right?
The patient was apparently alright 1 week back when he developed tingling sensation in both the lower limbs, which was insidious in onset, and it started distally over the sole of both the feet and then progressed gradually to involve up to the level of the knees in 2 days. And then there was complete involvement of both the lower limbs up to the hips after 4 days. The tingling sensation then progressed to involve both the upper limbs by the end of 5 days. There was no associated sharp shooting pain nor pins and needle sensation. There
Wait,
was
wait. So you had the history, that is in a 52-year-old man developing positive sensory phenomenon, and then the negative weakness. So at this stage, what do you think is happening? Which part of the neuraxis is involved?
Looking at these complaints, it seems to be that the peripheral nerves are getting involved.
Okay. Why the paresthesias and numbness? In peripheral nerve affliction, why do we have paresthesias and numbness?
So paresthesias, they are paresthesia are positive symptoms in case of peripheral
Right.
neuropathies.
Okay.
Uh,
How this sensation is carried to the brain? Why brain is feeling that, and why it is originating? What is the reason?
so the tract wise, I should say.
I don't know how the brain feels. Is it the how the impulse is felt by the brain?
So the impulses, the sensory system is divided into various tracts.
Okay, the receptor is stimulated,
Yes, sir.
but here there is nothing to stimulate. Once receptor is stimulated, then action potential is generated. The action potential conducts towards
Irritative lesions can cause.
irritative lesion. So what is irritative lesion here?
It can be some.
Is it the damage to the axon, the myelin? You understand where the
Can be the damage to the myelin.
myelin can cause, and axon can cause. Axon cut means there is negative, and moreover, suppose some lesion is there which is neither cutting nor destroying, partial damage, then there will be a generation of action potential which is conducted and giving rise to these phenomena. Okay. Next.
Patient then developed weakness over bilateral lower limbs since the last 3 days, which was acute in onset and gradually progressive. It was noticed by the patient as difficulty in gripping of the slippers, where he could put his feet in the slippers but couldn't grip the slippers. He was, however, aware that the slipping of slippers was there. He later developed difficulty in climbing the stairs and bearing weight on both the lower limbs. The patient said that the weakness involved both the lower limbs at the same time and it was equal bilaterally, and he felt that his limbs felt slightly loose. The weakness then progressed and now the patient is unable to move his lower limbs and is bedridden since the last 2 days.
Okay, so next major complaint is, first is sensory symptoms, then this is weakness.
Yes.
Right. So what is this sudden acute onset? You said acute onset. What do you mean by that?
So suddenly he felt after the sensory symptoms started, suddenly one day he felt that his lower limbs felt weak and he
So
couldn't grip his slippers.
how do I understand this acute onset? Means it could be stroke,
Yes, sir.
but you didn't say, the history is not suggestive of stroke so far. Why do you say the term acute?
So because it started immediately after those sensory complaints and he felt.
It is so. Is it vascular insult?
Doesn't seem like so.
Then the history should be different. So here there is a problem in your construction of story.
Yes.
You didn't exactly pinpoint when it started.
Okay.
So you assume that it is acute onset. That acute onset could be because of vascular lesion, a stroke. But it's not that correctly. No. How it developed? It developed over 3 days.
Yes.
In these 3 days, what acts he could not do? Or first act, what he could not do, which has made him think that he had weakness.
He couldn't grip his slippers.
So that you say that, na? So one day morning after getting up, or afternoon when after having lunch, neurology case is still storytelling.
Yes.
The story should be foolproof. Here there is a big hole. Where is the problem? Acute onset means acute onset. What is acute onset? You should say next day morning when after getting up he was not able to wear chappal, he noticed. Then when did he develop that problem of getting up from squatting position, climbing stairs? When was it?
So over the period of 3 days it progressed.
So it is not exactly, you have to time it. What time it has happened? After 12 hours or 24 hours. You have to depict the progression exactly. How it progressed. Okay. Next.
He later developed difficulty in climbing the stairs and bearing weight on both the lower limbs. He said that the weakness involved both the lower limbs at the same time and it was equal bilaterally and he felt that his limbs felt slightly loose. The weakness then progressed and the patient is unable to move his lower limbs now and he is bedridden since the last 2 days.
Okay, right. So, next.
There is no history of weakness of the upper limbs. There is no history of difficulty in turning or rolling in bed or getting up from supine position. There was no difficulty in lifting the head from the bed. There was no history of any breathlessness. No history of difficulty in chewing food or
So,
closing
up to
eyes.
no history of sharp shooting pain, you are dealing with motor complaints.
Yes, sir.
Right? Anything else anybody wants to ask? There are 16 participants or 18. Any one of you want to ask anything more about weakness? So whether there is no difficulty in lifting the head, right? There is no difficulty in. Did he have any difficulty in swallowing?
No, sir, there was no difficulty in chewing the food,
Ah,
closing the eyes, or
ah.
any breathlessness. No
So,
issue
in
like
your
that.
opinion, difficulty will be more with liquids or solids?
Sir, if there is more difficulty in solids more than liquids, then it points to some mechanical obstruction
Ah,
usually. And
right.
if it is if it has to do liquids more than solids, then there is some.
So, how do you elicit the history for liquids?
We ask him if after eating he has like when he drinks something, does it get stuck or something like that?
Not like that. Whether it comes through nose,
Okay,
nasal regurgitation,
usually.
whether there is any history of nasal regurgitation of fluids, right? Because he is not able to swallow choana of nasal, and they come out through the nose.
Yes.
So there is huge you didn't say about that. Okay, and what else? What do you want to say now?
There was no history of any band-like sensation felt by the patient.
Hmm.
No history of any bladder or bowel disturbances,
Hmm.
any sweating abnormalities.
Hmm.
The patient does not give any history of trauma or any history of heavy weight lifting.
So, history of bladder bowel disturbances, swelling abnormalities, cold extremities, and sexual difficulties, band-like sensation. These are all the sensory symptoms,
Yes, sir.
which are by and large are not there, except paresthesias
Anesthesia.
and numbness. And why do you say difficulty taking turns in bed or getting up from supine position?
Sir, I wanted to rule out any truncal weakness,
Okay. So you wanted to rule out weakness in the trunk and neck in between. How about thorax?
respiratory difficulties.
Did you say?
I've written it.
You didn't write.
Yes,
So you have to think of that. Then did you think that there can be weakness in
patient.
orbicularis oculi
There was
muscles?
no history in difficulty in closing the eyes, sir.
Hmm.
There was no history difficulty in chewing the
He
food.
won't say difficulty in closing the eyes. Now ask whether relations observed the eyes were open when he was asleep.
No.
Right? Possibly that will give you a clue whether he was able to whistle, is able to eat properly. That you have mentioned. All right. And now trauma. The next is so far in localization, you have dealt with sensory, you have dealt with motor,
Yes,
you have dealt with sphincters
yes, sir.
and autonomic nervous system.
Yes, sir.
Right? Why do you assume that it is a problem only in the peripheral nerves? You have to tell negative points about other areas in your axis.
Sir, to rule out spinal cord because these are sensory motor and
So how do you rule out in the history?
we ask about history of any trauma. If he has any,
That is trauma is etiology.
yes, sir.
You are at the history
Spinal.
of localization. So, what symptomatology will make you think that problem is there in spinal cord or not there?
Radicular pain,
There is no history of radicular pain, okay?
sphincter disturbances.
That you mentioned. What else? Sensory level.
So that I said there was no history of any girdle-like sensation.
There is no history of sensory level.
Mm.
Okay, that also will. Why not it is in brainstem?
So because I mentioned in the negative history later, there was no history of any diplopia. There was no
In
cranial-
history taking, there is nothing like negative history. There is no negative history.
There
History is
was-
localization history, etiology history. In localization history, you have to say positive things first and say that these things are absent. So the other individual gets an idea that where the problem is. Hmm.
There was no history of any diplopia,
Huh.
nasal regurgitation,
Hmm.
any history of any difficulty in chewing the food, or relative did not notice any that the patient's eyes were open while he was sleeping. No history suggestive of those things. So I don't think cranial nerve examination was the
Examination. we
cranial
did.
nerve history wise was not there. Sir.
Acha. Okay. How about cortex? Why did you rule out? Why did you miss some cerebral cortex?
Sir, if he had any things related to the cortex, he would have symptoms like headache, vomiting, altered sensorium.
So you have to ask, no? Why
Yes,
do you think that you got a clue? That's why you are telling peripheral neurology GPS. In exam, you should not present like this. You have to rule out all the cortical features. So instead of headache, vomiting, visual disturbances, suggest or raised intake pressure. What else?
Any altered behavior for frontal lobe.
Yes.
Then if there was any difficulty in dressing and all for apraxia,
Okay.
if he had any difficulty in calculations,
Right. Any difficulty in language, in speaking, in understanding, in obeying commands. right? So these are the things. There are no history of seizures, no memory disturbances. So these are all cortical localization features. The paraplegia you said, isn't it?
Yes.
Both the lower limbs are weak.
Yes.
Where all you get problem, both the lower limbs symmetrically. You said it is both equal.
Yes.
So where all a lesion can cause this? Bilateral lower limb weakness.
In case of either if it is a polyradicular neuropathy,
Polyradicular neuropathy or bilateral lumbosacral plexopathy, yes.
and it can also occur in diabetic lumbar radiculopathy.
That is
Numbers.
asymmetric. That is asymmetric. Alright?
Yes.
That is diabetic
Also,
amyotrophy.
it can occur in cases like transverse myelitis.
It can dorsal myelitis can happen. Right? There can be lower limb weakness. Where else? Where else paraplegia can occur? Participants? 21 of you are there.
So it can also occur in cases of thrombosis of unpaired ACA.
Unpaid ACA. Okay, good. What else can cause there? Parasagittal meningiomas, tumors which can cause pressure on paracentral lobule, which is
Yes.
where else it can happen? Probing. Cervicomedullary junction,
Yes.
where the motor fibers cross. Right? Various types of paresis can happen there. Monoparesis, cruciate, paraparesis, bilateral upper limb weakness. Anything can happen at cervicomedullary
So if
junction.
the lesion is at the foramen magnum, then it can
Yes,
Ellsworth phenomenon can occur, and he can have quadriparesis later.
fine. That's correct. But you are not telling? Right. Very nice. So let's go ahead. Etiology.
Yes, sir. Sir, there was no history of trauma,
Hmm.
no history of heavy weightlifting, no
Hmm.
history of any recent fever, cough, cold, loose stools, or any recent vaccination.
Why did you ask heavy weightlifting?
Uh, any trauma can cause compressive neuropathy,
Come to neuropathy.
compressive myelopathy.
Myelopathy. Which area?
So usually the lumbosacral.
But the lumbosacral region may cause cauda equina syndrome or radiculopathy, prolapsed intervertebral disc prolapse. Where does the spinal cord end?
It ends at L1. Sir.
L1 vertebra. So how can you get myelopathy there? Usually disc is at L5, S1,
Yes.
L4, L5, L3, L4. So it is cervical that is important. When you lift weights, if there is an atlantoaxial dislocation, right, the craniovertebral anomalies, they can cause problems. That's the reason. Why did you ask about loose stools?
Sir, I wanted to rule out any antecedent event which can cause paraplegia. We are dealing with polyradiculopathy.
Hmm.
So one of the causes is AIDP.
So you have to correct yourself here. It is not cause,
Antecedent events. Sir.
event.
Yes, sir.
Cause and relationship not established.
Yes.
It was only observed that there are antibodies to Campylobacter jejuni infection in AIDP cases in 36% cases. So it is not that one who suffers from stools, loose stools will get GBS.
Yes.
So there are other associations. What are the other associations?
Sir, C. jejuni is one association. Mycoplasma pneumoniae is one association. Uh, then other EBV is one association, sir. Uh, Recently, Zika virus is also been an association.
COVID. There are cases of COVID described. COVID 19. What else? Somebody is saying HIV, seroconversion, right? Other disorders, systemic connective tissue disorders may also be having pain. But most important things you have already mentioned, post surgery at times,
Sir,
sometimes immunological
old
reactions.
rabies vaccination had also
Yes.
relations.
Post vaccinal also can give rise to demyelination. Agree. Okay, next.
So there was no history of weight loss. There was no history of loss of appetite. There was no history of consumption of heavy meals prior to these symptoms.
Why?
Such paraplegia can also occur in cases of Hypokalemic paralysis.
Hypokalemic periodic
Periodic
paralysis.
paralysis.
What are the precipitating factors for hypokalemic periodic paralysis?
So heavy meal prior to those episodes.
Why?
Increased
What heavy meal? Sweets,
states.
where glucose is more.
Yes.
What else can precipitate? A strenuous work in hot sun. He worked for 12 hours, slept, and couldn't get up in the morning. So, two things which you have to ask. Okay.
There were no history of similar complaints in the past. There is no history of any alcohol abuse or high sexual behavior.
Hmm.
Uh, there is no history of any abdominal pain or any altered behavior.
Hmm.
No history of any recent or long-term medication use or Ayurvedic medication intake.
Ayurvedic medicine intake. Okay. Right.
Yes.
Uh,
No history of any numbness. So this is a
Again, you have gone back to localization. Once you have finished localization, you should not go back.
yes.
So ideally, all these things should have come, which we have asked with
Yes.
you. But why did you say perianal area? What is the reason? Where all you get sacral sensory loss?
Or in cases of conus medullaris.
And cauda equina.
Yes.
And when the spinothalamic tract ascends at cervical region, where are the sacral fibers located?
So in the spinothalamic tract, it is medial to lateral. This cervical is medially and sacral is laterally.
So whenever any tumor presses in cervical region on the spinal cord, the sacral fibers are involved first.
Yes.
So you will have a sacral anesthesia
Yes.
on that side. So you have to on the opposite side because the cross fibers.
Yes.
So we should know whether there is any sacral sparing or sacral involvement. Very good. Right, next.
No history of headache, vomiting, or cortical.
That you have mentioned,
Yes,
no?
sir.
But wrongly placed here, it
Yes,
should
sir.
go to localization.
Yes. Patient was admitted with the above complaints at the hospital since 1 week. The weakness in the lower limbs did not improve. The patient said he underwent a test in which pins were put in the lower limbs. He
Huh?
also-
Why do you say this? What pins? What do you think in this?
I wanted to see that NCV was done.
In NCV, pins were put.
CV and EMG both were done.
Right.
EMG.
Electromyography, that's correct. NCV is only surface electrodes.
Surface, yes.
In EMG, you get this. Okay.
He also said that he received some expensive injection for 5 days, but his complaints continued to persist.
Okay.
There was no other significant disease.
So you can tell what is that injection.
He was given IV.
So you expect IVIG to dramatically improve.
No, sir.
Then why are you saying that? But he complained that he continued to persist.
Sir.
You should reassure him that it will take 3 months.
Yes.
Okay. No other significant history.
Yes.
Next.
So to summarize,
Oh no, summary. Personal history.
yes, sir. Personal history. Uh, he consumes a mixed diet. The sleep has decreased.
Why? How do you explain sleep decrease?
Sir, he is anxious for his complaints mainly because of that.
Okay.
Sleep that could have been decreased.
Right.
His appetite is normal. His bladder bowel is normal.
Are you not interested in his alcohol intake and cigarette smoking?
Yes, sir, but he did not give any
But you didn't write.
Yes, sir. Did not give any history of alcohol.
How is it important for us in this case?
Sir, alcohol itself can sir. Cigarette smoking, he might get CA lung and some paraneoplastic thing can cause neuropathy. Sir.
In the management, does it affect? If lungs are emphysematous, he may require ventilation, which may be troublesome.
Yes.
It's also important. So when if he requires ventilation, okay, good. Past history.
Past history, there is no history of diabetes or hypertension, no past history of tuberculosis, There were no similar episodes in the past. His family history is not significant, sir.
Okay, summary.
To summarize, we have a 52-year-old male with bilateral lower limb paresthesia since the last 1 week, followed by bilateral upper limb paresthesia since the last 5 days, which gradually then progressed into paraplegia since the last 2 to 3 days. The patient feels loss of tone in bilateral lower limbs. There were no bladder or bowel involvement
Wait,
and no
wait,
others.
wait, wait. Don't rush. Don't rush.
Yes, sir.
So, what type of weakness is this?
It is a spastic weakness.
Very
It is
good.
a placid weakness, sir. Sorry, because he felt loss of tone.
You only said spastic.
No, no, sir.
So, what are the features that, where is the involvement? Lower motor neuron or upper motor neuron?
Lower motor neurons, sir, because
What are the features of lower motor neuron affliction?
so lower motor neuron will have a flaccid kind of weakness.
So, one is weakness.
Second thing is there can be significant wasting of the
Still, did you
muscles.
mention in your history that wasting? You didn't mention. Okay.
Third thing, reflexes are usually absent.
Reflexes doesn't come before something else. Fasciculations.
Fasciculations
You
are-
didn't mention in your history.
Fascic-
How do we understand? So in motor, whenever you take history, when you start with weakness, just follow the same order. After weakness, whether there is any wasting or no wasting, whether there is any stiffness or looseness, whether there are any involuntary movements or not. You finish off there only, otherwise you will get into trouble like this. So there is no wasting, there are no fasciculations, but weakness is there and there is flaccidity. Okay, very nice. Tone and no other complaints. Upper limbs are not involved.
Not involved.
Fine. Right. So where is the problem? Physiology wise, functionally, what does he have?
Functionally, he has paraplegia with paresthesia, sir.
Hmm.
Yes.
Okay.
Uh,
Physiology wise,
Physiology-wise, it is a flaccid paralysis, sir.
physiology
Lower-
means what are the tracts, what are the parts involved?
It seems to be a polyneuropathy, sir.
Nerve. Now tell me, in the lower limbs, what are the nerves?
So there is from distal, if we say there is a tibial nerve, anterior tibial nerve, and there is a sural nerve. Coming upstairs, there is femoral nerve, obturator nerve, sciatic nerve.
So you have nerves which are originating from plexus,
Yes.
which is called lumbosacral plexus.
Yes.
Isn't it? There are roots there. There are roots there, there are divisions there. Roots, divisions, and nerves. Some slightly different from brachial plexus. Here, brachial plexus, roots, trunks, divisions, cards.
Cords.
Here, it's roots, divisions, and nerves. Okay. So, all the nerves, what are the types of nerves? How are they divided?
Sir, they are divided as motor nerve.
About the conduction. Based on nerve conduction and diameter, you tell me.
So, small fibers and large fibers. In small fibers, we have A delta fibers and C fibers, and in large fibers, we have A alpha and A beta fibers.
Very nice. And free nerve endings? Right. Then how do you clinically differentiate which is involved?
Yes, sir. If it is the involvement of the large fibers, then patient will have symptoms like he will say there is loss of joint position, vibration.
He will say that.
Sir, he will say that he feels imbalance while walking.
Imbalance while walking.
Yes, sir.
Right? How do you differentiate an axon involvement from a myelin involvement, demyelination neuropathy, or axonal neuropathy from clinical history? History and examination. How do you differentiate? What are the features of large fiber neuropathy? One you said is imbalance, right? That is sensory ataxia. You will feel unsteady, especially in the dark. What are the other features? Anybody else? Other features? Large fiber neuropathy. Large fiber neuropathy. It can be sensory, it can be motor, right?
Large fiber, he will also have weakness.
Here weakness, very good, but no wasting.
Mm.
Because axon is preserved, axon flow is preserved, What type of conduction happens here in large fibers? They are fast conducting.
Yes.
How conduction becomes very fast?
So, my
Saltatory
jumps
conduction.
the.
Right. So in between two nodes of Ranvier, there is myelin, right? And by Schwann cell, and that myelin is disrupted. So that saltatory conduction is affected. The impulse is not getting transmitted, so there is weakness.
Yes.
When axonopathy, what happens? The axon flow is disrupted.
Yes.
Right? As a result, the muscle fiber slowly dies or atrophies. So you have wasting. So in 2 to 3 weeks of illness, if there is wasting in the limb, which is much more, then it is axonopathy. If there is a limb which is weak but not wasted and feels heavy only, that is demyelinating neuropathy or large fiber neuropathy. Then how do you identify small fiber neuropathies?
So patient will say complaints like there will be loss of pain and temperature
Hmm.
sensations. Uh,
So then you think it is small fiber neuropathy.
yes.
Or anybody else? Small fiber neuropathy definition. Sumiran? Srihari? Arohi?
Sir, Paris burning sensations,
Yeah, burning sensation. Who is telling?
positive symptom. Shreyari, sir.
Srihana, bolo. Small fiber
Uh,
neuropathy characteristic features.
burning sensation,
Yeah, good. So there
Autonomic
will be
fibers involved.
severe burning sensation. All the reflexes are preserved, no other abnormality, no loss of touch, no loss of sensation, but you have severe burning. You do nerve conduction studies, this is normal. So, patient complains of severe burning. On examination, you are not finding any abnormality, right? So, that's how you recognize the small fiber neuropathy, right? Then how do you recognize radiculopathy?
So radiculopathy, there will be root pains around the.
Oh, one is radicular pain, very good.
Second thing is, sir, the specific muscle group supplied by that radical weakness will be there.
Very nice, excellent. Third, so you said root pain, that is sensory complaint. There may be partial sensory loss in the dermatomal distribution of that. Second, there will be weakness. Third,
Asymmetry weakness.
reflex
Reflex.
supplied by that root. C5 root biceps gone,
Yes.
right? C7 triceps gone,
Yes.
right? L3 is knee, right? S1, L5 is ankle. So if those roots are affected, you have a reflex loss. So partial sensory loss, because the dermatomal type of sensory loss is always partial as compared to the sensory loss because of nerve damage. Because dermatomes overlap, isn't it? So that is the type. How do you assess the spinal cord sensory loss? What are the types of sensory loss in spinal cord problems? Yes, who's telling?
Saddle anesthesia is there.
dissociative,
Pardon? Yes, please.
dissociated anesthesia.
Dissociated anesthesia is one. That means the central canal in front of it, right? The fibers coming from substantia gelatinosa cross over and ascend second order neurons of spinothalamic tract, right? But the posterior columns which are uncrossed are not affected. So you get as a dissociate sensory loss. What else? Spinal cord.
So saddle anesthesia in case of conus.
Saddle anesthesia is down below. Very good. Next. Brown sequard.
Brown sequoia,
Brown
cerebral.
sequard type of.
Spinal cord.
Right. Very nice. One is Brown sequard, where central cord syndrome is dissociate sensory loss. Important things to remember, right? And preservation of posterior columns and involvement of spinothalamic tract is in what type of spinal cord involvement? Bilaterally, posterior columns are preserved. Bilaterally, spinothalamic tracts are damaged.
So in anterior spinal artery thrombosis.
Very good. Anterior spinal artery syndrome. It could be because of any reason. Excellent. So where you got weakness and spinothalamic affliction, but posterior columns are preserved. Very excellent, excellent, excellent. So you got a brown sequoia type, dissociate anesthesia. You got a saddle type, right? What are the types of sensory losses in cortex?
Sir,
Suppose there is a problem with the cervical.
Anisoprognosia.
Ah, yes, that's good. Cortical sensory type losses, if they are mentioning. Suppose there is a problem in the cervicomedullary junction. What type of sensory loss you can get? You got a problem around C3, C2. What are all the sensory disturbances that can happen in body?
usually the dermatome supplied will have sensory losses. Then C2, C3.
Okay.
So the
What else?
nape of the neck and all those
Right.
patient.
Nape of the neck, all those things. नहीं और बताओ. So C3, you show me your hand. Where is C3? Huh? C4?
C4 is the supraseptal.
Yes. C5?
C5 is tip of the shoulders.
Right. Okay. These are. What else can happen? Very nice. You said by C3, C2, if there is a spinal cord problem, it could be intramedullary tumor or intradural extramedullary compressing on the spinal cord. What are the other spinal, the sensory problems which you can have?
Sir, in cases of B12 deficiency SSC, there will be only posterior, predominantly posterior column involvement.
Not impressed. What happened to spinothalamic branch of fifth cranial nerve? What happens? The sensory, sending sensory tract. Yes, bolo. Bolo, bolo. What happens to the fifth neuronucleus, sensory nucleus? Spinal tract of trigeminal nerve comes down up to C2, C3 level, crosses and ascends up in the lemniscal pathway. If this is affected, you'll have facial numbness on the contralateral side. Have you forgotten lateral medullary syndrome? Where ipsilateral and contralateral pain and so that's also okay. Then next, what are the etiologies which you are thinking?
Seems more like a polyradicular neuropathy.
Mhm. Any other definitions you can give?
Sir, it can, the patient, it can also, I also was thinking in terms of hypokalemic paralysis, but he did not say any history suggestive of heavy meals.
How do you differentiate from transverse myelitis? Partial myelitis.
Bladder and bowel will be involved early in case of transverse myelitis.
Transverse is complete. Partial is partial.
He will at least have some sensory level, or he might feel some girdle-like sensation.
Okay.
At least some parts.
What else?
Fever at the onset is usually there in case of transverse myelitis.
Okay.
Usually absent in cases
Okay, we'll come back to that. What are the etiological factors for acute flaccid quadriversis?
one can be air disease,
Yes.
porphyria spincus,
Okay.
then toxin consumptions like
Okay.
botulism,
Right.
diphtheria spincus.
Okay. Acute flaccid quadriversis. बोलिए students, what are the etiological factors? Very important for exam. Acute flaccid quadriversis. Arohi, people who are not replying are absent
Thick
mark.
paralysis.
Yeah,
Infective causes. Thick,
infective causes. Okay,
thick.
why don't you think of neuraxis and tell where else you get what are the muscle problems, what are the nerve problems, what are the neuromuscular junction problems, what are
Nerve
the
problem.
spinal cord problems. You have to divide it that way. Causes of acute onset: myelopathy, cervical myelopathy, poliomyelitis, paralytic rabies, myopathies, periodic paralysis, hyperkalemic, normokalemic, thyrotoxic, consumption of fish and shellfish, ciguatoxin, tetrodotoxin, sea snake bites, Russell, and crate bites. right? Disorders of neuromuscular junction, myasthenia gravis, botulinum toxin, and acute neuropathies like AIDP, post-hepatitis, post-influenza, post-gastroenteritis, post-vaccinal, post-viral, right? Acute neuropathy, porphyria, diphtheria, organophosphorus, lead, mercury, thallium, tick paralysis. So, in your mind, it should be the neuraxis dependent classification because you are groping for answer. No? When I ask the question, what are the causes of acute flaccid quadriceps, you are thinking, oh, this. But you should have some framework which should rattle out the causes. Right, next.
Coming to the general examination, the patient was conscious, he was oriented to time, place, and person. His weight was 68 kgs. His height was 170 centimeters with a BMI of 24.1 kg per meter square. The pulse was 110 beats per minute. It was regular in rhythm, normal character, volume, force, and tension. There was no radio or radiofemoral delay. There was no arterial wall thickening. All the peripheral pulses were well fed. His BP was 128 by 76 millimeters of Hg, measured in the right upper limb in supine position. I couldn't measure his BP in the standing position, sir. His respiratory rate was 20 breaths per minute. It was abdominal thoracic type, and a single breath count was 22 per minute. Temperature was normal, sir. There was no pallor, icterus, edema, clubbing, or lymphadenopathy. There was no angular cheilitis. There were no neurocutaneous markers. The skull and spine examination was normal. No tuft of hair, no secretive.
Any other general examination findings?
Sir, there was no
Do you have
cutaneous
a
manifestations of TB.
tuberculosis? Okay, but what is the thyroid? Did you look for thyroid, thyromegaly? Because you were thinking of hypokalemia. So both are interconnected.
There was no acropathy or dermopathy or those features.
So, do you think we should look for oral candidiasis when you are thinking of HIV?
Yes.
Right? Should know. Should think.
Yes.
All right. Okay.
Nervous system examination, higher mental.
Well, I said you should talk of other systems first. I assume they're all good, normal.
They are normal.
Cardiovascular is okay.
Yes.
Respiratory,
Yes.
gastrointestinal,
Everything.
right.
Higher mental functions, appearance was normal, his behavior was normal, he was conscious and oriented to time, place, and person. His remote, recent, and long term memory was intact, his intelligence was normal, speech and language was normal. Insight judgment, abstract thought, calculation was also normal. His MMSE score was 28. Coming to the cranial nerve examination, sir, all the cranial nerve examination was normal, sir. Sir, the cranial nerve 1, there was no anosmia, sir, bilateral.
But did you do it?
I gave him, yes, sir, I did it.
How?
Sir, I did it with two objects. I told him to close his eyes first. I told him then to close one nostril, and through the other nostril, I gave him two objects. I told him to identify soap and coffee. He could identify that.
Okay. Next.
Sir, his visual acuity was normal bilaterally. Visual field by confrontation method was normal. Pupils bilaterally were reactive and 4 millimeters in size. The color vision was normal, sir. For checking the third, fourth, and sixth nerve, the ocular motility was normal in all directions, sir.
But you should say that I checked for saccadic, pursuedic,
Yes.
pursued eye movements, convergent, divergent eye movements, right? That and all the eye movements in each muscle of all the 6 muscles of each eye.
Yes.
You have tested, yeah, isn't it?
Yes.
So laterally there is no problem. Lateral rectus, medial rectus. Abduction. What are the elevators? When eyes are abducted, what are the elevators? When eyes are adducted, what are the elevators? When eyes are abducted, what are the depressors? When eyes are adducted, what are the depressors? You should know. So tell me, what are the depressors when eyes are adducted? Anybody? Okay. What is superior oblique doing?
Sir, it causes intorsion.
Yes. All the superior muscles cause intorsion, all the inferior muscles cause extorsion.
Yes.
Simple. Okay. Superior oblique, down on adduction. Okay, right. Chalo. Next.
The fifth cranial nerve, sensory component was intact, sir. Motor was
You
also
said pupillary reflex normal,
yes, sir.
right? So what is the pupillary pathway? How the pupillary reflex occurs? Light enters the retina, right?
Yeah.
Cones or rods are right stimulated. The impulses are conducted
But the optic nerve
to
to the occipital.
occipital.
Pretectal.
Where will they go?
Pretectal.
Srihari.
Pretectal nucleus.
Pretectal nucleus. Right? They won't go to occipital lobe. They go to pretectal nucleus. Heading a Westphal nucleus. They come back through a third nerve and cause pupillary constriction. Pupil can be constricted in what are conditions?
Poisoning.
Poisoning,
Time.
pontine hemorrhage. What happens in pontine hemorrhage? Why it is constricted? Anybody? Pontine, you are correct. But you should know why. Hmm?
Edinga vestibular. Edinga
Yes,
vestibular.
yes.
The
Huh?
skull gets
Bolo?
compressed at the level of clivus.
Bolo?
Edinga vestibular nucleus is like near the midbrain.
It is the damage of the central fibers mediating Horner syndrome. Central sympathetic fibers are coming from hypothalamus to Horner syndrome. Where is it coming from? T1. At T1 level, there is a ganglion. There are three sympathetic ganglion in neck. Stellate ganglion,
Okay.
superior middle, right? So the central fibers which are coming from hypothalamus reach T1 stellate ganglion. The postganglionic fibers will emerge and ascend along the internal carotid artery, right? The fibers which are mediating the sweating, they branch out along with external carotid. So that's the main differentiating feature where the lesion is in Horner syndrome. So pons, if bilateral or because of the central fibers, right? Sympathetic fibers. Okay, sensory motor Jajar ka fifth nerve. Next.
Seventh nerve examination was normal, sir.
Hmm.
Eighth nerve examination was also normal. Ninth and the gag was present, sir.
Gag only, you don't look at the uvula, you don't
Uvula.
look at the soft palate.
Uvula was
Gag
central.
is least important.
Uvula was central.
Your central. And soft palate is moving equally on both sides.
Yes. 11th nerve, the sternocleidomastoid power was normal, sir.
Hmm.
12th nerve, there was no deviation or on protrusion of the tongue, no atrophy, no fasciculations.
Hmm.
All cranial nerves were intact bilaterally, sir, at the end of it.
Hmm.
So for checking the nutrition, I checked his nutrition. These were the readings.
You think they are okay?
Yes, sir. There was no significant wasting.
Okay.
The tone, bilateral lower limbs, the tone was lost. The hypotonia was observed in
Hmm.
bilateral lower
Hmm.
limbs. Upper limb tone was normal.
Hmm.
In the power, sir, at the various joints, upper limb power,
All are normal.
upper limb all are normal, sir. Lower limb,
Huh?
at all the joints, sir, the power was grade 0, sir.
Hmm. So he is not moving at all.
No, sir.
No flicker of movement. Right. What is grade 3?
And grade 3 is movement eliminating gravity, sir.
Huh? Again is gravity.
Against gravity with some resistance. With
With
some
no
resistance.
resistance.
Yes, sir.
4 is resistance. Now there are gradations have come.
Yes, sir.
Grade 2 is gravity eliminated.
Eliminated, yes, sir.
Okay. Hmm.
The reflexes, superficial reflexes were present. The plantar reflex, however, was absent, sir.
Hmm.
Checking the deep tendon reflexes, upper limb reflexes, biceps, triceps, and supinator were 2 plus.
Hmm.
The knee reflex and the ankle reflex were absent, sir.
Hmm.
Cerebellar examination, sensory system examination was normal, sir.
Hmm.
Other systems were normal, sir.
Hmm. What is differential diagnosis now? You have completed the whole story. So you cannot have only one diagnosis. You should have two diagnoses. What are the other diagnoses which you have? At least one. Let us say if it is transverse myelitis, as I asked earlier, what is the difference now? Why you say it's not transverse myelitis?
There is no sensory level.
Okay.
There was no involvement of bladder and bowel.
Hmm.
There was no fever at the onset or history.
But your plantar is still mute.
Yes.
We don't know.
Yes.
If you are able to elicit a plantar response, right, we are happy.
Yes.
Now you say you are put us in a fix that whether it is right. Possibilities AIDP points, acute onset, areflexia, no. You got upper limb reflexes are present, flaccid quadriparesis, minimal sensory, no bladder bowel involvement. There are no points against except that areflexia. Right.
Lower limb air reflexes.
Lower limb areflexia is there, but that's not sufficient.
Paraplegic variant of AIDP.
Huh? So no variant. Huh?
Only the paraplegic variant.
So there are various atypical things come. So we always should talk of common things first, right? We should not go for abnormal things. Next, transverse myelitis. Points, acute onset, flaccid quadriparesis, flexor plantar. We don't know the plantar. No sensory level, no bladder bowel involvement. You correctly identified these two very important. And hypokalemia we rule out because of the history.
Yes.
Right. The provisional diagnosis will be AIDP. So investigations, anything?
No, sir. Nothing except for a CSF examination.
Okay. So special investigations, CSF and nerve conduction studies. Right. So CSF, what is it?
So the color was clear. There was no cobweb appearance. Total cells were 1. EDA value was 4.5. Sugars 90. Proteins were 329. And LDH was 63.
So albinocytological dissociation.
Yes.
So what are the causes of albinocytological dissociation? Other causes. Only one? AIDP? Anybody else? Quickly Google कर रहे हो?
So any condition which causes irritation of the subarachnoid space.
Oh, that is your knowledge, your intelligence working. Huh? Sri Hari, albinocytological dissociation causes. 23 are seen, nobody is talking. Nobody is talking. Patil Amaya. Varsha, what are the causes of albinocytological dissociation? Freund syndrome, spinal block, acoustic schwannomas, bilateral. You should know. So don't go by that only one investigation, right? Next.
Neuroimaging was also done for this patient, sir. It was nothing was only chronic small vessel ischemic disease.
Right, but we are interested in spinal cord, which you didn't do. Right? I said paraplegia can be anywhere, dorsal spine, cervicomedullary junction, it can be in the frontal. Only thing, frontal you have ruled out. Okay.
Nerve conduction studies, polyneuropathy picture in both the upper and lower limbs was observed, suggestive of PID.
So what are the electrophysiological signs of demyelinating neuropathy?
Sir, delayed conduction velocity, F responses.
Or prolonged. Distal latency is prolonged, but we have some other patients' findings here. So I'll show you. Slowing of nerve conduction velocity, distal latencies prolonged, F latencies are prolonged, and normally is about 30 in the upper limbs and 50 in the lower limbs. Second amplitude should be less than 50% of the first one. Okay, that is conduction block, and sensory nerve action potentials may be absent in this case or may be present. because in AIDP they are present. That's how we see the report here. The ulnar, the median, the sural nerve, they're all elicible. That means normal, and these are the compound muscle action potentials of common peroneal nerve, which looks normal. The F latency is 40 slight, and this is the uh, 3 milliseconds is the distal latency of this nerve. Okay, that's how you see. Here it is prolonged. The common peroneal nerve, it is 5 milliseconds. The amplitude is lost. So this is another abnormality that is noticed, right? These are the right common peroneal nerve conduction study in our. This is of F wave. See, the small wave which you see is F wave. So this wave is prolonged in this case, and so we see mainly for compound muscle action potential, distal latency, conduction velocity, and F latencies. So in motor nerves, in sensory nerves. In upper limb, we see median, ulnar mainly, occasionally radial. In lower limbs, posterior tibial and common peroneal nerves. Right? So these are the nerve conduction and CSF study, of course, you have already said. What are the diagnostic criteria of AIDP?
Uh, Modified
Price
Ashton.
and criteria.
Yes, as per his criteria, very nice. Let's really quickly go through them.
Yes, sir. A progressive weakness of more than one limb due to neuropathy, total areflexia, disease course should be less than 4 weeks, and absence of other causes for acute neuropathy like porphyria, toxin exposure, and diphtheria. And supportive criteria has progression of symptoms over 4 days to 4 weeks. Relative symmetry of symptoms and relatively symmetrical weakness should be there. Mild sensory symptoms or signs. The cranial nerve involvement, especially bilateral seventh nerve. Autonomic dysfunction, absence of fever at the onset, and albuminocytological dissociation in CSF, and nerve conduction study suggestive of AIDP. Exclusion criteria is abnormal porphyrin metabolism, recent diphtheria, purely sensory syndrome without weakness, past history of GBS, and severe concurrent medical events.
What are the important issues in the body neurosis?
So one of the issue can be if the patient develops any respiratory distress, they can go to ventilatory support, and
Very good. Next,
reassurance is difficult for.
what is the respiratory problem? Agreed.
Second thing, because the patient is bedridden and everything, a patient
Bed
can have a bed
sores.
sores.
Right. Autonomic nervous system disturbances. There can be
Prolonged
tachyarrhythmias.
catheterization.
Postural
Yes.
hypotension.
Yes, that's correct.
Bladder bowel, bladder involvement. The patient can have
So,
long catheterization.
main two issues, ventilation and autonomic nervous system in health. You got to do chest physiotherapy, frequent oral sections, DVT prophylaxis, respiratory and bulbar functions, right? These are very important. What is the definitive therapy?
No definite therapy. We can either try IVIG or plasmapheresis.
No, that is definitive. There are indications for definitive therapy. This is to be given either plasmapheresis or IVIG. So this is based on evidence-based medicine. Large trials were conducted. Which is better?
Neither of
Either of the two should be given.
Both are equally effective. But in older individuals, we don't prefer plasmapheresis because it is taxing. If he's got a heart problem, he will have more problems because you are draining your blood, cleaning it, and putting it back. So that's very dangerous. High dose IVIG or plasma exchange, both are useful. The indications of duration should be less than 2 weeks. Walks with support or bedbound. Patient having breathing difficulty or on mechanical ventilator. That means the person who can walk without support, you don't have to give. If it's beyond 2 weeks, 2 weeks to 4 weeks, you don't give. Is the treatment better? So we have trials which said both are equally. Dutch trial is one, and another trial is that PSGBS study group in 97. Both have said that both are equally good. And Netherlands study also said same thing. So you can see that you can use any of them, but think of patient's pulse. Don't recommend IVIG, which will rob him of all the savings he has in life. Okay, because the guarantee of recovery is at the end of 3 months. He might postpone the ventilatory support for a few days. All the trials have studied the recovery pattern at the end of 3 months. and where they found benefit in 36 to 40% cases. It is not absolute truth. Steroids were not exactly tested in a very large patients. That Hughes et al. Study had only few cases, so there is still a chance, and more studies are to be done with steroids, right? So that's how we should approach this case. And I think any other doubts you can ask. These are the three large multi-center control trials, and all the trials you should know on what basis they have started these treatments, right? So that's all from any questions anybody wants to ask, you can ask, otherwise we'll close the class. Any questions? Any questions? Okay then, if there are no questions, thank you very much. Right, we'll see you next time. Bye.